when you're given medication, the nurse is actually going to watch you take it. And that's the only way that they know that you actually took it. So they stand there and watch you. It's an amazing fact that because patients then go home later and they're given their medication, nobody knows whether patients take their medication. Nobody actually knows whether it's taken correctly, in the right dosage, forgotten. We also don't know whether patients experience side effects or need their dosage tailored. We really know very, very little.
The startup investment landscape is changing, and world-class companies are being built outside of Silicon Valley. We find them, talk with them, and discuss the upside of investing in them. Welcome to Upside.
Woo!
Hello, and welcome to the Upside Podcast, the first podcast finding upside outside of Silicon Valley. I'm Eric Hornung, and I'm accompanied by my co-host, Mr. WrestleMania himself, Jay Klaus. Jay, how's it going, man?
I have filled my cup of wrestling interviews this morning.
I never got into wrestling. I don't really get it, to be honest. I know that people got really into it, and I didn't expect you to be one of the guys who was really into wrestling.
I challenge anybody to watch 3 straight weeks of Monday Night Raw and not be into it. I think it's well done from a storyline perspective. I mean, it's a male soap opera, and the storylines are pretty compelling. However, I do think that it is in kind of a downturn. I think when I was rewatching it, or when I was starting to watch it again back circa 2013, 2014, was an interesting time. But they seem to have a troubling trend of going back all the way to like former superstars. The fact that The Undertaker is still wrestling, and Triple H and The Rock, I think they brought Stone Cold back recently. I don't think that speaks well to the future of the WWE. I think they need to be grooming new superstars, and they're leaning too much on the legends who have charisma on the microphone, but are less fun to watch wrestling because they're just old guys.
I watched The Rock's first wrestling match, and that was pretty cool, but I watched that like last year in retrospect. Obviously, it's been 15, 20 years or whatever since that moment in time. But I had a wrestling video game. I think it was WWE versus the World or something. And I don't really remember much about it other than Hulk Hogan might have been in it and some guy with a painted face that I always was.
Well, specifically this morning, I was watching a bunch of interviews about CM Punk's exit from WWE, which happened when I was watching. CM Punk is a wrestler. I don't know what else you want me to say.
Yeah, but like, what's he look like? What's his thing?
He looks a little bit like you. He is not. He's not physically gifted. Like, he's a very average-looking guy with long, greased-back hair. He had a lip ring and taped his hands and had an X on them because he was the straight-edge wrestler. He didn't smoke. He didn't do drugs. He was like the hero of not falling into temptation. But then he turned heel. And he was very outspoken and very aggressive against the establishment. And when he quit, he did this like monologue on air live, just like really ripping apart a lot of the organization, which was fascinating. And then when he left, he was quiet for a long time. And then I just found recently that he did a 2-hour interview about his exit that I found to be just very interesting to rewatch this morning.
I like how you said he's just like you. He's not physically gifted. He has greased back hair. He didn't smoke or drink or anything, taped his hands, had a lip ring. In what world? Like, it started off as a insult, and then it just got, I don't even know if it was an insult after that. It was just, that's how you imagine me? You imagine me like walking out of Upside and just like having a fight on air before I walk out?
It's not direct one-to-one, but in the face, I see a little bit. In the face and in the hair, there are some similarities.
Okay. All right. Anything that would be interesting to our audience here come out of that interview, that 2-hour interview?
What he talked about a lot was one of the big reasons he left was his health and how he was not well taken care of by the organization, which is something that I've heard anecdotally recently as well. All of the wrestlers are actually independent contractors, but they join the WWE because they grew up loving wrestling, and that's like the one show in town. So the organization has a ton of leverage and in a lot of ways really takes advantage of these guys. And they'll end up leaving with horribly like broken bodies and addictions and just bad news bears.
Well, speaking of health and hopefully better health, today We are talking with who, Jay?
We are talking with Sebastian Seiguer, the co-founder and CEO of emocha Mobile Health. emocha is a mobile health platform that saves lives by connecting remote patients to healthcare providers. They improve medication adherence using video technology and human engagement. Basically, emocha provides direct observation via recorded video in their applications to ensure that people are adhering to their medications in the correct doses.
Do you think there are any wrestlers that use emocha?
I don't know.
Well,
Maybe.
that's a good answer right there.
emocha was founded in 2014. It's based in Baltimore, Maryland, our first company in Baltimore. They've raised close to $2 million in seed funding to this point, and another $4 million in non-dilutive funding through the National Institute of Health's Small Business Innovation Research Program.
Love some non-dilutive funding, Jay. That's a thing here on Upside that we are a big fan of.
That's true, and it seems like it might also be a university spin-out technology, which is another trend that we've pulled on. I already have a sniff that this is going to have some similarities to our script drop interview when we talk about patient adherence, so it'll be interesting to hear if this is a complementary or competitive approach to the same problem. But without just speculating more, why don't we just jump in and talk to Sebastian?
Let's do it. And if you have thoughts on this episode, reach out to us on Twitter at UpsideFM, or if you have something a little longer, send us an email at hello@upside.fm.
Hey guys, wanted to give you a quick note and ask for a quick favor. Eric and I have once again entered the South by Southwest Panel Picker competition to have a panel, or maybe two panels, at this year's South by Southwest Festival. Last year, you guys came out in droves and voted for our panel and gave us the opportunity to go and speak with people at South by Southwest about geography versus investing. Does location matter? And this year we have two panels up for vote that we would appreciate your help in supporting. Eric, you want to talk a little bit about your event?
Yeah, so mine is quite the tongue twister, Jay. So if I get through this in one take, it's going to be impressive. It's called Capitalist Running a Cashless Fund. I nailed it. It's about what Jay and I are doing here on the podcast, which is essentially running a venture capital fund without making investments of money, but instead making investments of time and giving people media attention. I think this idea can apply to a lot of other spaces, and we're going to tell our story and also talk about other ways that you can think like an investor, act like an investor without making specific investments. What do you got on the docket, Jay?
My panel is called Connecting Tech Communities Outside Silicon Valley. It's not nearly as fun to say as yours, but this is a panel exploring the ideas of how to connect community builders and different ecosystems across the country to one another. It's sort of this platform role for community that we've talked about more than once here on the podcast. And so if you guys wouldn't mind tossing us a vote, you just have to go to upside.fm/vote. I'll say that again, go to upside.fm/vote. Please give us a vote on both submissions, and hopefully one of them comes through, and we'll see you again this year at South by Southwest in Austin, Texas. Sebastian, welcome to the show.
Thank you for having me.
On Upside, we like to start with a background of the guest. So can you tell us about the history of Sebastian?
Absolutely. So I'm a Baltimore native. I grew up here, eventually ended up going to college and law school in New York. Yeah, I've got a brother, I've got a sister. My parents were both docs. So healthcare has always been, I've grown up around healthcare. Actually, my sister is also an infectious disease doc, as is my wife. After law school, I worked in London for a year at a law firm. They were sending me to Munich, Germany for a customer pretty much once a month. And when I was going over there and staying in beautiful Munich, there was nowhere to get a cup of coffee. And I ended up starting a coffee chain from scratch in Munich. I expanded it throughout Germany. At some point, so this would have been 2009, 2010, we were at 25 locations, and I thought it was I liked it. It was fun. It was quite social, and it's always nice when you get something right. We franchised it out, so we were giving licenses out. It was very exciting, but I wanted to do something more impactful. Ended up selling the business and moving back to Baltimore, and worked with Hopkins to find my next thing, which I had determined was going to be in healthcare, because the people around me, they are so motivated to do what they do, which is help other people in some way. And the cash register opening all the time was a nice sound in the coffee world. But doing something that will help other people is a great way to do business.
You said you were in law school when you were traveling to Munich?
No, so I graduated law school in 1998, and my first job out of law school was in London at a big corporate law firm in the city center there.
And so, family of doctors, you became a lawyer, and then at some point you decided while in Munich, I'm going to start a business. Was that something that was new to you? Had you ever done anything entrepreneurially up to that point?
So I'd always had a lot of ideas that were completely stupid and unworkable. A lot of the the friend group I had in law school was jumping off and doing internet businesses rather than go into law. And coffee was the best thing I could think of at the time, to be quite honest. And although I did enjoy the practice of law, I really didn't see myself. I didn't have a role model there in a firm where I could see myself just practicing law forever. It just didn't seem like the right fit for me.
What kind of corporate law were you doing?
I was actually doing derivatives law, which is documenting contracts for trades, futures, options, things like this. So it's really interesting.
Yeah.
Yeah, exactly. Just like coffee and healthcare.
I'm curious about coffee because I'm one of the guys that goes to a coffee shop and I'll sit there for 5 hours using the Wi-Fi, drinking a single cold brew or cup of coffee. How does the model behind coffee shops work? What makes a successful coffee shop?
So a lot of different things, but maybe a couple points just for the purpose of this interview. When coffee is of a high quality, consumers will drink more of it. They don't really think about that. They're not judging it, but their body can't handle bad coffee. So that's a basic consumption point. But in the end, coffee shops are a real estate play because you can control every single cost. And to a certain extent, you can drive your revenue, but your location will determine everything because, there's only a certain amount of revenue you're going to do out of a location and your rent is going to steadily increase. So that business model requires serious real estate acumen. When I started that business, I knew absolutely nothing about business. I was an inexperienced lawyer. I was 27 years old. I had no clue about anything. It is a miracle that we survived the first 3 years, an absolute miracle. And the only reason we did survive is because there were absolutely no coffee shops in Munich and everybody wanted American type coffee. And we named it San Francisco Coffee Company because Germans love California. And so those two facts right there was no coffee on the street and Germans love California. That's a business model.
Wild.
When you exited that business, was that a significant liquidation event? Like, did you need to work again? 25 coffee shops is a lot of coffee shops.
It was not a significant liquidation event. It was enough money in my pocket that I felt good about having spent 9 years, running a retail business. And it was enough that I didn't have to work for a couple of years. So I did an MBA at Hopkins in healthcare. But no, it was not. So actually, when I started San Francisco Coffee Company, a company called Seattle Coffee Company had been bought by Starbucks at a valuation of £1 million a location. So, that's where my mind was going. And then I met the head of Starbucks Europe at a conference 3 years after I started the coffee chain. And I asked him, well, how are things going with Seattle Coffee Company that they had taken over? And he said, you know what, Sebastian, the biggest mistake Starbucks ever made was buying that chain. So,
wow.
Yeah. So, we sold to restaurateurs who could afford to pay out somewhat at, an okay valuation, but no, not a major event.
So you went and got your MBA. I think I saw on your LinkedIn that you ended up at Johns Hopkins Technology Ventures. And so I'm interested to hear what that next step looked for you after you took a couple years off and dove into the next phase.
Yeah. So I was, at that point, like a 37-year-old Columbia law grad, and I worked for $12 the hour at the Tech Ventures office. I was very open with them. I just said, look, I want to know every piece of intellectual property that's here because I want to start a business out of something here. And I will do, to sit here, I'll do whatever you guys need done. So I ended up analyzing these, the license agreements and helping chase royalties for them for a couple of years. But at the same time, I got to meet some amazing inventors. And I got to meet a team in infectious disease led by Dr. Bob Bollinger, who's a world-renowned HIV and TB expert. And they created a software. And the software was quite basic, but it was compliant with the big healthcare regulation, which is HIPAA, and had been in operation for 4 or 5 years. So it was emocha, which is what they had called it, was one of the first mobile health platforms ever invented, with the first app going out in 2008, meant for helping patients with HIV in rural Uganda and ripe for commercialization.
Real quick question. How much IP was there at Hopkins? You said you wanted to see every piece of it. So like how much was there?
So more than I could possibly have seen. They will file about 200 patents a year. And so there are, I was quite naive going to healthcare and having a strategy like that to like sit at a tech ventures office. I mean, the diversity of intellectual property is tremendous. There's genes being patented. There are therapeutics. There are assays. And I ended up in the area that I could understand, which is software. To make the coffee chain with 25 locations profitable, there is no way to do it without software. And we had configured our own setup from cash register to inventory management to personnel. And I knew our personnel spend, I knew our cost of goods, and I knew revenue down to the detail every single morning. There was no way to be profitable without software. So software was something I could understand. But at the same time, no technology ventures office in the country really understands what to do with software, because it's very hard to patent, and copyright protection is not really a scalable, protectable piece of intellectual property. So to be honest, there was more than I could see, more than I could understand. And that's actually the big problem in tech ventures in general, is that there's just too much there.
So you gravitate towards this software play called emocha. Was it called emocha before you started looking at it?
Yes, and that's important, because I would never come from the coffee business and name a company something that's similar. And I didn't like that it was so similar to something I had previously done, but the team of scientists had named it emocha, Electronic Mobile Comprehensive Health Application.
Oh, it's an acronym.
Yes.
Emocha could easily be the name of an online coffee shop.
It could.
Or the software behind a coffee shop. Crazy. So we've had a few university spin-out technologies on the show, and before we dive deep into the pure emocha, kind of model and customer, I'd love to hear about the process of using that IP and what that has looked like for you.
So the relationship with the team at Hopkins is very, very deep right now. As you can imagine, software develops based on end user needs and market needs. And so what we started with has almost nothing to do with what we have today. From an intellectual property perspective, it's very hard to look at what we have today and see from a pure lawyer point of view, how these two things are matched and how they align. But from a relationship point of view, I see our licensing of technology as a relationship. And I would attribute at least 50% of our success to that team at Hopkins, and 50% of the success to our team that has just really, we've been very capital efficient. We have made a massive improvement in healthcare, in the public health space, and impacted thousands of patients already. So I would say that, looking back, we were, in addition to licensing a reference software, which we could use to build future iterations of a product, we got ourselves into an amazing relationship with great people who really care about patient care and who wanted entrepreneurs to help them get their technology into the commercial domain. It's been really awesome, and one of the nicest parts about this company.
So how would you describe to the listener and the new user of emocha what emocha is today?
So today, emocha is a platform which helps patients take every dose of their medication using video technology. That's what we do.
And how does that work?
So first of all, maybe a little bit of background on the problem that we address, if that's okay.
Yeah.
This is maybe a medical or scientific fact you may be aware of. When patients don't take their medication, it doesn't work, right? So the only way for medication to work is when the patient takes it. And that's a huge problem.
Makes sense.
Another fact is that when you're in the hospital and you get treated, you may notice, I don't know if you guys have been in the hospital anytime recently, but whether it was in the past or whether recently, when you're given medication, the nurse is actually going to watch you take it. And that's the only way that they know that you actually took it. So they stand there and watch. It's an amazing fact that because patients then go home later and they're given their medication, nobody knows whether patients take their medication. Nobody actually knows whether it's taken correctly, in the right dosage, forgotten. We also don't know whether patients experience side effects or need their dosage tailored. We really know very, very little. So about 40 years ago, for certain diseases, the standard of care became observation, watching a patient take every single dose of their medication. And today, it remains a fact that the best and only proven way to make sure that patients take their medication is observation. So with that background, our system allows for the two major factors in making sure people take their medication to be scalable. And those two are observation and engagement with the patient. So first of all, there's patients use a smartphone application. They download it to their device. They video record themselves taking their medication at every dose. And they also can message with their provider to ask any questions they may have or just to let them know how they're doing. On the other end, the provider or our team, depending on the customer, reviews the file and then messages back to the patient at every single dose to keep them on track. We develop a habit, and we've proven that we can achieve the same rates of adherence. So adherence means taking your medication as if you were to perform this technique in person, as it's been done for 4 decades now successfully for several diseases.
What are the main reasons for non-adherence?
There are a lot of different reasons, and that's why you're not going to just throw technology at this one and solve the problem, or AI, or whatever else you want to throw at it. The simple reasons that lay people think of is that people forget. Then come some more subtle ones, like patients are sick and they take their medication and feel better, and so they think they can stop. There are basic access problems that are really hard to fix, like you can't afford medication, which is becoming, with Medicaid coverage expanding, has become less of an issue, but it's still a problem. And then there are some concerning ones, like, the medication actually makes the patient feel really sick and they're experiencing a side effect, which could be quite dangerous for them. So a lot of different reasons.
You said that either the provider or your team messages them back at every dosage. That seems very labor intensive to just constantly be monitoring people's doses. Can you just walk me through how that looks?
Yeah.
Is there any way to make that automated?
Yeah, so the question is, what do you want to automate in this process? This gets to the role of technology and the role of humans in healthcare. I'll just take a step back real quick to answer your question comprehensively. One more time, the only way that you could possibly secure medication adherence to a high rate is directly observed therapy. There's no other proven method for an oral or an inhalable that's taken daily, okay? So what does that process consist of? It's observing the patient. In theory, you could automate that. But what happens when something else occurs, like the patient asks you a question or their skin coloration is a little different? There's all sorts of other things that relate to medication that you could also observe, and that when you're in person, you can talk to the patient about. So think about it this way. Directly observed therapy is a comprehensive, holistic way to secure adherence. When you're going digital, there are things you can automate and things you can't. So I could, perhaps we actually can, and I won't go too deeply, but maybe we know that a video consists of a patient taking their medication. But what if the patient is outside and it's 20 degrees out and they're wearing a t-shirt? I want to tell them that they should, put on a jacket. What if the patient then also asks a question like, I'm not feeling too well right now and I'm feeling lightheaded? What if that's a major, major adverse event from that medication? So if observation was the problem, it would be solved today. It's not observation. It's everything else around engaging with a patient about medication.
And so what does that look like for your team in terms of, like, who's doing the observing? They have to also have other responsibilities, right? So from a pure number standpoint, if I'm a nurse, I probably oversee dozens, maybe hundreds of patients. How does this actually work logistically?
Right. So the vast majority of our customers right now are doing the observation themselves, and they're doing it because, let's say in public health or in academic medical centers, some of them have capacity and they have an interest or a financial reason to do that. As we get into health systems, health insurers, they do not have the capacity to do that, and we have to fulfill that. We started with our first customer late last year, a health plan in Maryland, and we started with layperson coaches, meaning non-clinical. And now we are adding clinical people because the questions that come up may need a clinical lens. So our team makeup was layperson led until very recently, and now we're adding nurses and pharmacists.
What is the requirement for someone who wants to be a layperson? Could you make this an Uber, you sign on and you get paid some rate to do this? Or does this person need to have some level of training or certification?
The Center for Disease Control has a standard for a directly observed therapy worker. And that's what public health departments, every single public health department in this country, there's 3,000 some public health departments, they will, for example, for tuberculosis, they will monitor every single dose using a directly observed therapy worker. They recommend training and a high school degree for those type of workers. Of course, every public health department also has nurse supervision and physician supervision. So these directly observed therapy workers are quite well trained and supervised. To your question, could you Uber this? You could for certain things, mostly observation. But I think that our current strategy is to bring the clinical perspective in and then ramp down to lay people as we start to understand all the various questions that are coming in from patients.
How many patients can an average clinical person cover in a day or a week or a month or whatever you track?
With our current technology, it'd be about 100 in a day. And I think that we should be able to, using technology, get that up to about 150 or 200.
And what is it in a hospital right now? How many could a observer track?
I think it really depends on the patient, the condition, and it depends on why they're doing it. So I would say that currently, in public health, one single person won't handle more than 25. And they're also responsible for other aspects of care. So it's not just about, you don't have people in our customers, and it's about 75, 80 customers right now. They won't have people who are only dedicated to using emocha. They're doing other things too.
You said that this is video recorded by the person who is taking the dosage. So these observers aren't observing in real time. They're looking at some sort of archive of video footage?
Correct. They should review within 24 hours, though, because a lot of the communication that happens on the platform has nothing to do with whether they took their medication or not. So for it to be relevant, it's got to be recent. So we try for a very short turnaround on reviewing the video and engaging back.
How is the user incentivized to use emocha?
You're talking about the patient now?
The patient.
That's a great question. It's actually the heart of the matter. In public health, the motivation is that it's twofold. One, I don't have to come to the clinic. I can do this from home. And nobody's going to come to my home because sometimes people from the clinic will come to them. The second really interesting motivation is that we work with patients who are in really hard situations. The diseases are very dramatic. Tuberculosis, HIV, diabetes. Some of these patients have very hard lives. Having another person who actually cares about how you're doing is very, very important to them. So that somebody noticed that you missed a dose yesterday, that somebody cares why it is that, this diabetes medication is hurting your stomach because you don't have enough food to eat. Having that other person on the other end is massively important. And a lot of these patients are quite isolated. So that's a big motivator. We're experimenting with a couple other models as well. So we do have 2 studies ongoing where patients are paid. They're given a financial incentive at every single dose. I think that may work for some patients, but it's not going to work for everybody.
Where they're not being paid, is the healthcare provider saying, we recommend you use emocha, or are they saying, as part of your treatment, we expect you to use this every day?
So the latter method is the most effective. There's something called the default bias in behavioral economics, which shows it's been proven that when a caregiver, a doc or a nurse, says that the default standard of care They state what that is. So, for example, you have to use emocha. The patients are more likely to accept it. Obviously, not all patients are going to like to video record themselves taking their medication every day.
You said you guys have 75 to 80 customers now. Break down for me what the typical customer is. Is it the payer? Is it the healthcare system? Who is actually paying for this to exist?
We have about, so that number was quite rough. But we have about, let's say, 60 public health departments all over the country that are using emocha, and they're paying for it. So these are municipalities. Probably about 15 academic medical centers using emocha, mostly in the research or clinical trials context. So they're testing a medication, or they're testing, they want to isolate whether patients take their medication or not, because otherwise they just don't know. And now we have 2 payers using emocha and 2 health systems using emocha.
Why aren't there more payers and health systems in your kind of purview? I feel like they have the most incentive to track this.
I think you're absolutely right. And that's where I think all of our growth will be in the next couple years. So first things first, we go one step at a time and we nail one market at a time. We are the standard of care in public health. As opposed to a lot of digital health companies, we have real patients, well over 1,000 a day, recording videos and actually using our system. And that has really helped us develop the product. Now, as that market has become our sales process is quite regimented, quite efficient, and our time from, let's say, presenting emocha to selling it and implementing is quite short. Now we're ready for other markets. And here's the biggest learning we've had. In health systems and payers, there is zero appetite to use a new technology. So earlier this year, we recognized that our business model going forward is a complete turnkey medication adherence solution. That means that the only thing a payer or a health system has to do is enroll their patient in emocha, and then we will do the rest. More interfaces, more provider-facing interfaces, more alerts, more information is not helpful right now. Physicians, nurses have too much to do on the digital front. Electronic medical records are, in the lifespan of healthcare, relatively new, and they're struggling. They're underwater with data entry.
What about the data that comes out of emocha? How does that feed into what is existing in the system now?
We have never before seen data. We are seeing when patients take their medication, what side effects are related to it, what other things that they're doing besides taking medication that could impact their health care. We know at about 12, 13 doses whether a patient is going to be adherent. And that's great. That's an amazing thing. But what'll be really interesting is that as we learn to pick out these patterns across different disease states, we'll probably know in advance where a patient's going. And what does that allow you to do? I mean, having that data means absolutely zero to a provider unless you can intervene. And that's actually the point. We will know when to intervene. We'll know that, for metformin at about 30 doses, patient's going to start having stomach problems. And we'll know that well in advance and start, interacting with the patient to change diet, perhaps to reevaluate which medication they're on at the right time. So it's incredible. And I think that over the next couple of years, the data set at this point, we have well over 500,000 videos on our data bench. So it's interesting.
500,000 videos. How many patients is that?
Off the top of my head, I couldn't tell you right now. I would also like to keep that to myself, if you don't mind. But, let's say on a day like today, we'll get over 1,000 videos.
Yeah. I hate to this does so much public good, and I see how much this can do for people. So I almost hate to ask this question, but healthcare is one of these regulated industries that for someone starting a business or for someone looking to invest in businesses in this space, they're saying there's money to be had in healthcare. So is the value proposition for capturing value here in this space cost savings to payers, to systems? Is that what you have to kind of hinge on? Or is it like this proprietary data where you can say, we can help you create better drugs?
That latter point, the data aspect, comes later. For right now, we continue to be in the same position that we were in 5 years ago. The reason why health systems are bleeding money for patients who have been discharged is medication adherence. That is the problem. they don't want to, or they can't recognize that right away because nobody knows what's happening at the patient's home. Everybody knows that patients have problems with this, but the major reason why it can't be recognized is because the feeling that they can't do anything about it. And that's just the case. Like health systems, payers, they know that this is a huge problem. They feel they can't do anything about it. And throwing technology at it, there are smart pill bottles that you open them, they send them, there are text reminders. All of these things have been proven to not do much. So we have a massive opportunity. It's probably one of the biggest opportunities in healthcare. If a patient with diabetes or COPD goes home and they take half of their meds, they're coming right back. Period. If you sit down with any health system and you ask them, you ask their case management team, you ask their CMO, how much of their medication are your patients with COPD taking? They will get very concerned right away. So for us, our sales cycle, we are poised to take over these markets very, very quickly now because there is no solution out there. There is nothing working. And we have just validated with about 3.5 years of data that we can hit really high rates of adherence, and we're actually doing it all over the country.
Is there any risk for, whether it's your lay people, observers, like do you guys have any liability of what you're reporting and if there's an adverse consequence after the fact?
I would think so. I think not really if it's a lay person, and we'll try to disclaim as much of this as we can. I think when we get into clinicians who are licensed reviewing videos, I think that there is a little bit of risk there. I also think that the regulatory environment and the legal environment in general is really actually the opposite. It's encouraging of these technologies because people are geographically isolated. They can use every tool that they can. So for example, CMS, so Medicare now reimburses for the review of a patient-submitted video as of January 1st. So there's actually reimbursement to use something like emocha, and I don't think that liability is a major concern for us.
If you bring on a bunch of payers and health systems at a pretty rapid rate, how does scaling your observation team look when you want to target clinicians? Like, is there enough supply out there?
Yeah, I think that's a good point. I think that we will be starting with clinicians in order to get that model nailed down, but we will eventually follow the exact same model that public health has followed, which is lay people doing observation for the issues that they can catch, which will be about 90%, and triaging the other 10% up to clinical staff who can provide the right answer.
Similarly, I'm just curious, in this environment, what does the pace of, like, when you talk about reimbursements, how does the actual flow of money work between different players in this space, and how long does it take? Like, is that a concern with just cash flow growing a business like this?
Yes, you can't rely on reimbursement. I don't believe you can rely on reimbursement as your business model. That's a mentality in healthcare referred to as fee for service. Generally speaking, the model is moving to value-based, which means you've got to be able to reduce costs for your customer. I think we're in a fortunate spot that for a payer or for a health system, if you can solve medication adherence for a small percentage of high utilizers, you will save thousands and thousands of dollars. So I think you're right. If you rely on any one strategy, if you rely on any one market, it's going to be very capital intensive, and you're going to need a lot of venture backing to take those losses.
How has the venture backing gone for you to date, and what are you looking at in the future? Is this going to be a venture-backed model or bootstrapped, or what are we doing?
Yeah, I've followed quite a mixed approach here. So on the one hand, I was in the retail world, and cash flow was king, right? So we had our first customer within 3 months of launching emocha, and we're selling software at about 6 months. So we've always had revenue. That's important to me. But it's healthcare, so you've got to validate your technology, otherwise nobody's buying it. So we've been really, really lucky to be based out of Baltimore with Hopkins roots because the National Institute of Health is right here. And they've provided over $4 million in non-dilutive capital for us to do our product development and validation. We've also raised about $2 million in seed funding. And so our philosophy is the venture money is to grow the business. The non-dilutive cash is to build the product. And hopefully venture money plus product money gets you the revenue it takes to be profitable and sustainable. I do think, though, to bring on a clinical team, we will now need to take on, venture funding. So we're looking at a Series A towards the end of the year.
What does that look like in Baltimore? What is the venture capital scene in Baltimore?
You have a core group of angel investors who are really committed to the city. And you have also some public institutions. One of them is Maryland Tedco that will back startup companies. I'd say that about 60% of our venture funding came from Baltimore investors, and the rest came from Silicon Valley investors.
How big is your team right now, Sebastian? What's it look like?
We're at 23 people.
And what's that breakdown of the type of roles? Is it a lot of technology people? Is it like a clinical team?
Right. So we have 2 clinical people, 2 people who are lay people for reviewing videos. We are at 4 or 5 engineers, 4 or 5 design product people. The rest are business. So sales, marketing, and let's say, yeah, that's about right.
Are the contracts in healthcare and municipality space, are those pretty sticky? Like once you're in, you're just kind of in for a while?
I've been told that, and we have had no churn, which is great. And I like to attribute it to the fact that the product is great and they love it. They absolutely love it. And it helps them. It works and they can do their job in a much more efficient way. So it seems pretty sticky so far.
When you go to a health system or a payer, who are you talking to sell this product to?
Well, remember, there's only 4 customers, right? In those 2 spaces. So far, it's resonated with the chief medical officer and the head of pharmacy. Because the head of pharmacy is very aware of this problem. Their strategy is get refills up because that's what their pharmacy partner, their PBM, is going to be also a proponent of. So if you get refills up, then at least patients could take their medication.
Yeah, we had a company early on in the days of this podcast that's based here in Columbus that their model is making sure that the patient gets their medication in the first place because they found this problem of it's hard to even get it in the customer's hands sometimes. How big of a role do you see that playing in adherence? Like how much of that is a hurdle?
Well, it's a great baseline, right? So if patients don't have their medication, they can't take it. So that's very important. But let's say who is the most expensive patient in the entire health system? That patient has 100% of their medication, of their very expensive medication, and they take none of it, right? Because then you have the pharmacy cost and you have really poor healthcare outcomes, which translate into costs. So I think that for patients who have 0 to 20% of their medication, they have an access problem. Getting them their medication is very important. For people who have like half of their medication, if they took it, they'd need to refill it. And for patients who have all their medication, you better make sure that they're actually taking it. Otherwise, you've got an extremely out of control pharmacy spend.
Does this model translate to outside of the US?
It does. I think that, a few disease states, let's say tuberculosis, are bigger problems outside the country than they are here. And in single payer systems, you have a bigger public health footprint. But we're really focused on the United States, where, let's say, innovation in healthcare is moving faster than in other countries.
How do you price something like this?
So our coaching service, I can tell you how we're pricing that. It's about $290 per patient per month. I'll take a lot of things into consideration there. It's really expensive to have a nurse doing that. We have to be really efficient and spend only a few minutes on every single video. Otherwise, we're going to be losing money. On the software as a service side, we're trying to hit a certain percentage cost of goods, right? So we want as high a margin as possible. And part of that is just having a really good product that doesn't require maintenance. So yeah, in this case, I guess on the healthcare system side, on the payer side, you've got to look at the total cost that a patient is generating. High utilizers, let's take COPD. High utilizers for COPD are costing $10,000 per patient per month to a health system, or even to a payer, either one. So there's a lot of margin there, and a lot of room for efficiencies. But they're also doing a lot of things to try to help those patients at the same time. So we're competing against all sorts of other things that have nothing to do with adherence. So we're pricing it in a way that, if we have a few thousand patients, we're going to be in serious, double-digit millions of revenue, and that's a good starting point.
You are deep into healthcare at this point, and I'm sure even with a family background, you thought you knew a lot about healthcare, but I'm sure at this point there's still things that are absurd or difficult for you. So what was the most unforeseen challenge of entering the healthcare space?
The most unforeseen challenge. Well, I think that's changed over time. At the very beginning, I was just shocked that there was no technology in healthcare. I couldn't believe that all the technology innovations that were available were not available in healthcare. And I think every non-healthcare entrepreneur who goes into healthcare probably feels the same way. At this point, I would say at the rate of technology innovation, I am just still in shock that it's so obvious that when people don't take medication, nothing actually happens, and that the health system isn't dropping everything to go figure out how to deal with that. But at the same time, I'm really very, very happy that we get to take pole position on this one and drive a solution. And then maybe the last thing is this is healthcare is a long one, right? It's a long road. You might pick off one or two opportunities that go fast here and there, but in general, regulation, entrenched practices, evidence, which is required, means that your play is a little bit longer. You got to be a little bit more patient.
So neither Jay or I have a deep background in healthcare. Is there anything that we should be asking that we're not asking?
Yeah, maybe what else is out there for solving this problem? I mean, if it's such a big problem, what else is there?
What else?
I guess what else is there?
Yeah, I got a great question coming up here. What else is out there for solving this problem?
So you have a lot of attempts that are inadequate. So there are certainly programs and there are certainly technologies that are inadequate. Many of them are focused on securing observation. So there are AI image recognition type of attempts. There are digital sensors, which if you swallow them, then it recognizes that it's in your stomach. Because all of these focus on observation, they're not going to be sufficient because what they'll do is they'll tell you that patients are taking about half of their medication. On the other hand, you have health systems that are sending nurses to people's homes to take care of all sorts of things, one of them being whether they're taking their medication or not. And those programs can be effective for certain things. Like, for example, I know one health system, they're sending repair people to people's homes because they want to make sure that patient that got discharged with COPD, that they don't trip and fall on, a broken step or carpet that's up, because if they fall and go back to the hospital, they're not getting reimbursed for this, right? So there's a lot of things happening here. And then the most interesting one that I find is patient education. So you've got call centers that call patients to educate them to take their medication, which is a really interesting approach. My father was a doc. He was very educated about healthcare. That didn't stop him from enjoying South American wine and smoking 2 packs a day. So, educating people, there's actually a strong evidence base for the fact that does not work, because it doesn't even work on educated, healthcare professionals. So not a lot of adequate solutions out there. It's an open market.
Wild. Maybe we need more stick than carrot.
Need a combination of both. So, how do you get people to do something, right? Well, you can get them to do all sorts of things that are entertaining. It's really hard to get people to do things because it's better for them. It just is very hard. And that's one of the challenges that we're up against. We have to figure out how to motivate patients to do this. The stick has helped in public health to a certain extent because it's the default. In the broader market, we'll have to motivate patients.
Awesome. Well, Sebastian, this has been fascinating. Thank you so much. If people want to learn more about you or emocha after the show, where should they go?
They should go to emocha.com. And we're also available on @emocha health. If you look at Twitter, you can also one day go step into your local health system.
All right, Eric, we just spoke with Sebastian Seiguer of Emocha Mobile Health. Back into some uncomfortable waters for us in healthcare and health tech.
Yeah, man. It's just a space that I don't get. I can speak for you here that it's not your bread and butter. I think we should have someone on as a coffee chat to kind of talk to us about healthcare, med tech, just how this ecosystem really works, because it is confusing.
Med tech is a better word than health tech. Yeah, I even spent a year in this space, and it's still pretty confusing to me. You have all these different stakeholders. You have the patient who's getting the care, and you have the doctors who are providing the care. You have this group of providers outside of that. You have health systems, you have hospitals, you have independent physicians, you have payers. You have this whole weird suite of what does insurance look like around this outside of just your typical payers. There's a lot of stakeholders, and the confusing thing for me when it comes to companies like Emocha just comes from, where do you actually get paid as a startup? Who's actually paying you, and under what terms are they paying you? How are they paying you? When does this become a big thing? It feels like people look at healthcare and they say, oh, there's so much money. It's such a big opportunity. But when you dig deeper, it's like, for who, and who's paying for that opportunity? And those are some of the questions I still had here with Emocha, but we'll try to work through that here in this deal memo.
I think we can start kind of there, because so much of, I think, what I've learned from the healthcare system is that the products that are coming to market in terms of startups are helping the patient most, but the patient isn't the customer. So how do you kind of balance who's feeling the pain, no pun intended, as in terms of the patient, and who's paying, and do they feel the same level of pain? So the maximum value here is probably going to go to the patient, but they're not going to be the ones paying directly for this service.
And that's another kind of axiom that happens in this healthcare space is people say, well, insurance companies will pay for this because it saves them money. I hear that so often. Insurance companies will pay for this because it saves them money. I can't imagine how often insurance companies are just hit with companies saying, we're going to save you money, pay us. And I wonder what that process looks like from there, from that conversation. Does that payer have to really come forward and say, yep, this absolutely costs us a ton of money, this is what the value is to us? Or how much of it is proving on behalf of the company that, hey, I bet this costs you a lot of money. Does it cost you about this? It just seems hard and inaccessible and cloaked to actually know what it is costing an insurance company, because they have to have these models on the back end that are serving their underwriting and their risk, that as a startup company, it's probably really difficult to understand. And you have to do this dance with them to figure out, okay, when would you pay for this? How would you pay for this? How much would you pay for it? Meanwhile, you're trying to survive and pay your bills and pay your employees and pay for research and development.
Yeah, the life of a med tech startup. I think one thing I like about Sebastian, we'll transition to the founder here for a second, is that he kind of comes from a medical background in terms of family. So his whole family's in the medical space. He's been kind of surrounded by that growing up, even though he ran a chain of coffee shops out in Europe for a bit. And he has that business experience. He went to Johns Hopkins, which is one of the largest and probably best medical research institutes in the United States. Very prestigious. And to navigate this world, you have to have that experience, that exposure. And I also think it's a pretty good sign of his ability to navigate by the first customers that he brought on, which are these academic centers, research institutes, people that are studying this space so that he can learn better about how to attack this space from a commercial side of things.
I definitely felt a lot of comfort, and I felt at ease talking to Sebastian. Even though this was such a difficult to understand model, the technology is not that difficult to understand. We're talking about medication adherence and people watching somebody adhere or not adhere to that medication. Conceptually, it's easy to understand. The model is what felt difficult, and Sebastian was very comfortable in answering all of our questions. It seemed second nature to him. He did not feel rushed by timelines or crunched by timelines or cash flow. It seems like they have paying customers now. They've gotten some non-dilutive capital in the past. He seems very in control of the relationship with the research institution that this technology came from and the people who developed it, even though the product itself has taken a very different shape since pulling it out of that research institution. So as a founder, pairing that interaction and that experience with Sebastian's noted track record of the coffee shops, I feel good about Sebastian as a founder. Like, I trust that he is navigating things and figuring things out and feels on top of it himself.
One quick shadow I have is just the scalability of this. So it's definitely more efficient. I think he said your current clinician can see 20 people, can observe 20 people in a day, or your current observer can observe 20 people in a day. And now this is one observer observing 100 patients a day. So that's a 5x increase. With getting up to 150, that's a 7.5x increase over current. I mean, that's a huge efficiency boost. My question is more on the scalability of this. Every time I think you read up on nurses or clinicians or anything, you have this supply issue where there's not enough nurses, there's not enough doctors, there's not enough of these trained people. And their model is to first start with clinicians before they get to lay people. So if they get a big enough customer, how do they scale quickly to meet that demand in terms of both number of observations they have to make and number of people that they have to train and get on their platform?
I agree. That was a little bit of a question mark for me too, that even though we asked it and he spoke to it, I still just couldn't quite grasp or feel totally comfortable with. If everybody who is taking medication needs to adhere to it, and we can ensure that best by having observation, who is observing these people, how many hours a day, what level of accreditation do they need? He said the CDC has a standard for observation therapy, which is training in a high school degree. So maybe that's a shift in employment for some of these people who have to shift employment because of technology. You know, you hear the argument all the time of when people are not afraid of automation, they say, well, there's going to be new jobs that are created that you can't predict. And this feels like it's actually something that fits into that camp of new jobs that are created that you might not be able to predict. But I still can't grasp the math quite.
The proverbial truck driver becomes a smartphone observer.
Yeah. So let's try to back into a little bit of math right now, which is going to be rough, but we're going to try. So emocha has 75 to 80 customers now, 60 of them public health departments that are seeing over 1,000 patients a day, 15 are academic medical centers doing research and trials, 2 are payers, 2 are health systems. Those last 2, payers and health systems, is where they really want to get into, which seems like where he believes the money can truly be, but they don't have a lot of appetite for new technology, said, and there's just not a ton of them as far as total market in absolute numbers, as far as like the number of payers, the number of health systems. But right now, they're generating approximately $290 per patient per month. And so with those disparate numbers, you start to see how this feels like it could be a big opportunity. If you got into one of the payers, already in 2 of the payers, so if those payers are really pushing emocha as a tool for the patients under their purview at $290 per patient per month, you get a pretty big number pretty quickly. I don't think I had any number on margin or how much of that is, takeaway for emocha. So things are still a little obtuse for me, Eric.
Yeah, I would agree. I don't think this immediately falls in our it's so big we don't have to worry about it number. I think probably going through the TAM calculation with some more numbers would be something I would want to do for this opportunity. $290 per patient per month. Is that high? Is that low? And by high or low, I mean, is it going to revert? Where's the mean? Is it going to revert up? Are they discounting themselves right now? Or is it going to revert down? And because they're operating at a smaller scale, they get to charge more and they'll get some downward price pressure from larger customers. I don't know which way it's going to go. I think that I would want to do more math around understanding, like, are we talking about a potential $1 billion business? Are we talking about $100 million business? Or are we talking about something much, much bigger?
What's the opposite of a shadow? I guess an opportunity. Something that was spoken to that we didn't spend a lot of time on, but seems like some real upside. There we go.
Wow, look at that.
The titular adjective. Some real upside potential here is the proprietary data of knowing how and when people are using medication and being able to intervene when that's not happening appropriately. He said that is data that they have that no one else can quite match based on how their model works, which does seem like big opportunity because if you can intervene, that is going to be somewhere that, anecdotally, I definitely understand insurance companies are feeling pain there. If people are not adhering to their medication, it's a big problem. And if you can show when to intervene on that and effectively intervene, that is a big opportunity to save the system some money and save a lot of lives.
Love that. Love saving money. Love saving lives. All good stuff, Jay.
All right, Eric. So what are you looking for 6 to 18 months from now from emocha?
I want to see those last 2 categories of customer. Are those payers and providers? Are we getting more of those signed up for pilots, for trials? Are there contracts being signed? Are there contracts in the pipeline? What does the reception look like in terms of price point? Is that going up or down? So I just want to hear more about the commercial development side of emocha. What about you?
I would agree with that. I was looking at specifically the revenue per patient per month for emocha in the context of payers and health systems as they roll out more of those customers. I'd also say I'm interested to see what their onboarding process or what their plan looks like for scaling the supply side of their marketplace, their observational users or observation therapists, so I can understand better what that plan looks like moving forward. Well, if you got some numbers or understanding of this company that we missed here in the deal memo, we would welcome your thoughts. You can tweet at us at UpsideFM or email us hello@upside.fm. We have to hear it. If you are somebody who is deep in the med tech field or know someone who is, that would be a good guest to enlighten Eric and I. You can also email us hello@upside.fm.
That's all for this week. Thanks for listening. We'd love to hear your thoughts on today's guest, so shoot us an email at hello@upside.fm or find us on Twitter at UpsideFM. We'll be back here next week at the same time talking to another founder in our quest to find upside outside of Silicon Valley. If you or someone you know would make a good guest for our show, please email us or find us on Twitter and let us know. And if you love our show, please leave us a review on iTunes. That goes a long way in helping us spread the word and continue to help bring high-quality guests to the show. Eric and I decided there were a couple things we wanted to share with you at the end of the podcast, and so here we go. Eric Hornung and Jay Klaus are the founding parties of the Upside podcast. At the time of this recording, we do not own equity or other financial interest in the companies which appear on this show. All opinions expressed by podcast participants are solely their own opinion and do not reflect the opinions of Duff & Phelps LLC and its affiliates, Unreal Collective LLC and its affiliates, or any entity which employ us. This podcast is for informational purposes only and should not be relied upon as a basis for investment decisions. We have not considered your specific financial situation nor provided any investment advice on this show. Thanks for listening, and we'll talk to you next week.
Never mind, bro, that can't be matched. I'm lighting it on fire, used to run victory laps, and still I'm not even tired. It's all about the timing, yeah, that's what they say. Well, I'ma keep on rhyming, find a way.